So, sella turcica is going to be, if I enlarge it, is going to be this radiolucent concavity, which is the home of the pituitary gland. Most analyses use the center point, which is called S. We use the most inferior point, SI, okay? And in that area, you can see that teardrop. That teardrop is the way you find PNS, pterygomaxillary suture. Then nasion. Nasion, if you look closely here, see that how the two bones join at that suture? Nasion is the point N, which is the frontonasal suture, just there. If you follow this all the way down, you can see the nasal bone. Orbitali is basically the eye, or the hard tissue that supports the eye. The point we look at is this point, which is we look at the superior point, but the point that I just showed is the inferior. So that's inferior orbitali. We need superior orbitali, okay? Now again, you're going to have some patients, because they're really asymmetric in the face, or because their head was like, you'll see two hard tissue lines. Again, you do the middle, right? So you draw both lines and halve them. Point A is the old way of representing maxillary position, and it is the innermost curvature. And where the mistake is, people just go for this. If you look at your skull, that will be the thicker cortical bone, but yet the most forward part will be trabecular like that. So don't put that as point A. That's why I like using ANS, because it's very distinct. It comes to a point, okay? And for the Jefferson analysis, he uses ANS. Point B, known as the innermost curvature, which would be here, is a different point to Pagonian. So the innermost curvature is B. So SNB is a relationship of the mandible to the cranial base. SN is anterior cranial base. The angle SN to B, that angle is tells you where maxilla is. If I draw a tangent from B to the occlusal plane in the Witts analysis, that gives me an idea of maxilla to mandible. But Pagonian is the point we use to anterior arc. Everyone happy with that? And the lower point will be menton. Now, gonion, as you can see here, if you look at the research by Bjork and Skeeler looked at growth of the jaw by placing titanium implants. They realized that jaws either grow forward or backward or neutrally. They term the term backward growth rotation for a long face. Why? Because at this point, the jaw grows this way. So you'll see an antigonial notch, meaning in a long face individual, you'll see a little step deformity there. So gonion is important for us to construct the mandibular plane. This is a good X-ray, or someone who has perfect symmetry. If you have two lower borders, again, like orbitali, you're going to halve them. Now, porion is the most difficult point to pick, because look at what you're looking at. I think it's almost like, you know that game kids play, pinning the tail on the donkey when they're blindfolded? That's porion. Why do we need porion? Porion's used for Frankfurt horizontal. That's why I don't like using Frankfurt horizontal. It's the biggest error. If you look at all the research and you ask even clinicians who've been doing this for years to try and pick porion, you'll get like dots everywhere, okay? So my advice, don't use Frankfurt horizontal. So the term ANS, if we look at our little teardrop, can everyone see that? And you follow that little teardrop all the way down, it hits the maxilla, that is PNS. Happy? At the front, can you see how distinctive this is as opposed to guessing at 8 point? The curvature comes to a point that's ANS, anterior nasal spine, posterior nasal spine. If you draw a line from ANS to PNS, all of a sudden you have maxillary plane, also known as palatal plane. Okay? And PTM is a good point to superimpose for facial growth because it doesn't really change. So Rob Ricketts, who developed this superimposition point, he used PTM, and from that he was able to predict facial growth of individuals. And we'll talk about that in later lectures when we talk about retention, because we superimpose your end of treatment Ceph over your original Ceph, but we superimpose over points that haven't changed so we can see what happened to the growth of the face. So our cephalometric points then, just to go through them: superior orbitale, inferior orbitale, porion, cella, cella inferior, nasion, ANS, A point, B point, pagonian, gnathion being that point of curvature, menton being the lowest point, gonial angle or gonion. So with those points, you can do any cephalometric tracing in the world. And this is the thing. When you buy a cephalometric electronic software, digital software, once you put those points in and you go trace them correctly, you can press a button for Ricketts, for Jefferson, for whatever analysis you want to do. Does that kind of make sense to people? The points give you the thing. But what planes you use will determine what analysis you use. I don't like Frankfurt horizontal. Why? Because even though you go from inferior orbit, which is easy to trace, this one, porion, is always debatable. Okay? So what I like to use in place of Frankfurt horizontal is the maxillary plane. Now, occlusal plane, remember, that's an incorrect occlusal plane. Because if you look at the research by Witts, the proper occlusal plane actually has nothing to do with the incisors. It's the line of best fit between the premolars and molars, deciduous molars, molars, right? Please get that right. That's a common error. Mandibular plane, menton to gnathion, to pagonian. Now, I will occasionally ask you to present two vertical analyses. One would be the Jefferson, okay? Another one could be lower anterior face height, 55%. Another one is called the y-axis. The y-axis goes from cella, right, down to gnathion. Cella gnathion gives you the angle that the jaw is going to grow. So you can have a long face or a short face or a neutral face based on that. And the reason I liked that is because if you've done your Jefferson tracing wrong, you might have a y-axis that's showing normal growth, but a Jefferson tracing showing long face. And then I'll say, well, go for a third analysis, because it's so important you get the right vertical. What would be the third analysis? You could just measure lower anterior face height, which would be, again, a measurement of, I'll find it in a second, a measurement of your A point down to your menton. It could be ANS down to menton, depending on what analysis you're using, and that should be 55% of total height, right? So when you do vertical, don't just say, right, I've done my Jefferson analysis of 100% fact, because vertical can be unpredictable if you've done the wrong tracing. If you present to me a y-axis and a Jefferson, bang, I know straight away. And the y-axis is dead easy. You've already got cella inferior, easy to find cella. You've already got menton and pagonian, easy to find the curvature gnathion. Draw that line, and that line in relation to anterior cranial base will give you an angle, and that's the angle we talk about for long face, short face. And we'll go through that in the vertical lectures. But I just want you to understand terms. Planes are the horizontal. Axes are the vertical. So when I talk about division 1, I'm saying that the axis between the upper incisor and lower incisor, the interincisal angle.